Hi, very good morning. I'm Dr. Janak Patel. I'm a general physician. I'm not an endocrinologist. Today we'll be talking about one of the endocrine hormone, that is ADH hormone, secreted by posterior pituitary. Actually manufactured, synthesized in hypothalamus, secreted by hypothalamus, stored in neurohypophysis and released from neurohypophysis. That is we call as a posterior pituitary. So we'll be talking in detail regarding that particular hormone. It is also called as vasopressin, antidiuretic hormone, or vasopressin, or arginine vasopressin. There is another name also, presophysin. So these are all the different names. We'll be talking on introduction, actions, or what we call function of ADH, regulation of ADH, different disorders, what are the investigations, differential diagnosis, treatment and complications. In short, we'll be talking on those. Now you can see here, these are what we call as the neuroendocrine cells. Neuroendocrine cells will secrete different types of hormones from hypothalamus. There will be two groups of cells we call as a paraoptic nucleus, paraventricular nucleus and supraoptic nucleus. ADH hormone is secreted by supraoptic nucleus. So supraoptic nucleus, whatever ADH hormone they secrete, manufacture and they secrete, it will be transported from here via these axon fibers, and that will be stored in a vesicle at the lower end of this particular axon. And this is a neurohypophysis. And whenever there is a stimulus, it will be released into a portal system. And through that portal system, it will go and act on a distal convoluted tubule of kidney, and it will reabsorb water. We'll be dealing in detail. So we are going to talk only on ADH hormone. So synonymous term already we have told you, presophysin, arginine vasopressin, or we call AVP or ADH. It is synthesized by supraoptic nucleus of hypothalamus, or also called as a magnocellular neurosecretory neurons. And they are in the form of a post granule, also called as a herring bodies in those neuroendocrine cells. It is stored in neurohypophysis, and the carrier for this particular hormone is neurophysin 2. So it gets attached to neurophysin 2, and then it goes and acts at the level of kidney. It is basically a 9 amino acid polypeptide. Molecular weight is 1000. Half-life is 16 to 20 minutes. It is rapidly metabolized by liver and kidney. And there are different receptors called V1A, V1B, V2. In kidney, it acts on a V2 receptor. That is, kidney is containing a V2 receptors. And mode of action is by G protein coupled receptor, and it is cyclic AMP mediated. Now, there are some stimulus, common stimulus, which will give rise to release of ADH hormone from neurohypophysis. One of the most potent stimulus is hypotension, fall of blood pressure. We'll be showing you in a subsequent slide how hypotension produces that particular, because hypotension will produce fall of blood pressure, which will stimulate baroreceptor, and this baroreceptor will stimulate hypothalamus to release ADH hormone, and further release of ADH hormone from posterior pituitary into portal venous system, and that will go and act on a kidney. So one is hypotension. Second potent stimulus is hypovolemia, decreased blood volume. That also is baroreceptor which will be stimulated. And osmolality means whenever there is a decreased blood volume, osmolality will increase. And this is also one of the potent stimulus which will be there. We'll be dealing in detail as we go further. There are few which are not related to osmotic pressure or not related to the blood volume or blood pressure. That is pain, fear, stress. We call a non-osmotic stimulus. This also gives rise to release of ADH hormone, which will increase blood volume, will increase blood pressure, and that will help the person during pain, fear, and stress. So we'll be going through all those particular things. Now you can see here that hypothalamus releases ADH hormone, and that ADH hormone will go and act on the kidney tubules. That is, we call as a distal convoluted tubules. Will be acting on a distal convoluted tubules. And on a distal convoluted tubules, it will produce retention of water. While acting on a peripheral blood vessels, it will produce vasoconstriction, by which it will have a vasopressure action. It will help in increasing the blood pressure. So these two actions are because of water reabsorption in distal tubule by acting at the level of V2 receptor through cyclic AMP, and contraction of the vascular smooth muscle, that is generalized vasoconstriction, and that is by acting at the V1 receptor. It is called V1 receptor, and that is via calcium channel. Now this is a diagram which shows you how it acts on a distal convoluted tubule. This vasopressin will combine with vasopressin receptor which are present on distal convoluted tubule cells, and as it combines, it activates the cyclic AMP, which will be a second messenger signal which will stimulate the storage vesicle which is containing aquaporin 2. This particular will come to the surface from where the water will be reabsorbed. So as it comes here, now this is an aquaporin pores, we call aquaporin 2. So that comes to the surface. This vesicle will come to the surface, and this will allow, now this aquaporin pores will allow water to be absorbed, and that water will be transported from the tubular lumen into blood, and it will increase blood volume. And by increasing the blood volume, cardiac output will be increased, blood pressure will be elevated. As well as vasopressin also acts via V1 receptor. It acts via V1 receptor on a peripheral blood vessel, producing vasoconstriction. And by producing vasoconstriction, peripheral resistance is increased and blood pressure is elevated. And that is how the action on kidney and peripheral blood vessels are there. So there are three receptor which has been identified: V1, V2, and V3. V1 receptor is present on a vascular smooth muscle where it produces vasoconstriction. It is also present in liver. It also acts on a platelet, and it also acts in a brain as a neurotransmitter substance. On a platelet, it increases the platelet adhesion, and by increasing the platelet adhesion, this is a minor effect, but it does produces platelet adhesions. And acting on a vascular smooth muscle, it produces vasoconstriction. On liver, it produces glycogenolysis. By producing glycogenolysis, it increases the sugar level. By acting on a V2 receptor, it is as an anti-diuretic hormone, where via aquaporin action, we already showed you in a previous slide, this slide, that it increases the reabsorption of water. And by increasing the reabsorption of water, water is retained, blood volume is increased, cardiac output is increased, and hence there is an elevation of blood pressure, and blood volume comes back to normal. In pituitary gland, it increases the action of ACTH release by CRH. So enhanced ACTH release is done by CRH, and that is accentuated by vasopressin, or we call as the ADH, acting on pituitary corticotropes. So on a corticotropes, CRH is acting. This will enhance the action, and there will be release of ACTH. So this is a small action, but it is present. So physiologically, we already told you water reabsorption, maintenance of blood volume, vasoconstriction, and maintenance of blood pressure. It takes part in maintenance of blood pressure, and also it augments the action of CRH by stimulating ACTH release from adenohypophysis. These are called physiological action of ABP, or we call as ADH. There are many other action of ADH which are minor. We have already told you antidiuretic, vasoconstriction, glycogenolysis. It also acts as neurotransmitter substance in a brain at some of the areas. It accentuates the ACTH secretion from adenohypophysis by increasing the action of CRH. Additional effects, it acts on intestine by increasing the contraction of the smooth muscle of intestine by increasing the peristalsis. And this particular property is sometimes utilized in a person who has got a decreased peristalsis, particularly in a post-operative person where there is a decreased peristalsis, or before even taking an X-rays where you want to expel out the gas so that you can get the best X-ray picture of abdomen. Also, there is a partial effect on a gravid uterus during parturition, that is during delivery. It increases the contraction of uterus. Ideally, the oxytocin is acting. It has got a partial action like oxytocin. Hence, it also increases the contraction of uterus during parturition. So these are the additional actions. Main action, antidiuretic, vasoconstriction. These are the two main actions. These are all additional actions. Regulation of any particular hormone will be either by a positive feedback, by a negative feedback, or by circadian control, or we call chronotropic, or by hypothalamic control. Here, there is hypothalamic control and there is a negative feedback mechanism. Now, basically, most potent stimulus is the osmotic stimulus, volume, that is hypovolumia, which will stimulate the baroreceptor, and through baroreceptor, it will release angiotensin II, while osmotic receptor will be stimulating the hypothalamic neurons, and that will release what we call as a ADH hormones. And there are other stimulus which we call as a non-osmotic stimulus like pain, nausea, surgical stress, certain drugs like morphine, nicotine, barbiturate, alcohol, opiates, antagonists, etc. All this will act at the level of hypothalamus. They will increase the thirst as well as it will give rise to release of ADH hormone. And this ADH hormone will be released because of osmotic regulation or because of the volume regulation. So if there is a fall in 10% volume, in circulating volume, baroreceptors are stimulated, angiotensin II is released, which will have increased thirst, and that will have increased intake of water, and that is how it will partially help in increasing the circulating blood volume, as well as osmotic regulation wise 2% increase in extracellular fluid or 2% increase in extracellular fluid osmolality. CNS osmoreceptors are being stimulated. There is the release of ADH hormone. There is an antidiuretic effect on a kidney, distal convoluted tubule. Water is reabsorbed, which will be poured back into circulation, will increase the blood volume. And as soon as the blood volume comes back to normal, ADH release is inhibited, as well as there will be inhibition of angiotensin II. So this will be the way in which the AVF secretion occurs, and it will help in maintaining osmolality and maintaining the blood volume. So this is the way the AVP secretion. So osmotic regulation and blood volume. So this is a diagram which shows you the entire thing. So if there is increase in osmotic value of an extracellular fluid, so the extracellular fluid becomes hyperosmotic. Osmoreceptor in CNS gets stimulated, and that will stimulate ADH, and that will have an effect on what we call as a kidney and will retain water. ADH will reduce urine volume, water is retained, and there will be negative feedback through osmoreceptor, and again this ADH hormone will be inhibited. While baroreceptin in aorta will be stimulated, those baroreceptor also stimulates the ADH hormone secretions, and that will also helps in maintenance of volume by increasing what we call as a reabsorption of water, as well as because of ADH hormone increase, there is also vasoconstriction, which will increase your blood pressure, because this is the effect on the peripheral blood vessels, which will increase the blood pressure. As soon as the blood pressure comes back to normal, negative feedback inhibits the baroreceptor, no more further secretion of ADH hormone. So dehydration will produce decreased blood volume and increased osmotic pressure. So whenever there is a decrease in the water content, there will be stimulation of ADH hormone secretion. So this is one of the diagram again showing you separately hyperosmolality of extracellular fluid, receptor in hypothalamus will be stimulated, more release of ADH hormone, action on kidney, reabsorption of water. Also, it will stimulate the thirst center, increase water intake, and there will be dilution of extracellular fluid. As soon as the dilution of extracellular fluid takes place, osmolality comes back, and this it will inhibit the release of ADH hormone, and it will also inhibit the thirst center. So this is a negative feedback. Same way, blood volume, loss of blood or loss of water, less pressure in right atrium and great vessels. So baroreceptor gets stimulated, less now impulse to hypothalamus, more ADH release, more water reabsorption from kidney, as well as the thirst center, water intake increase. Finally, extracellular fluid volume, again negative feedback. Too much of water drinks. If upon there is a high water content, so brain will be stimulated. Brain will produce less ADH, less absorption, less volume of water is reabsorbed at the level of kidney. Urine output will increase, large volume of dilute urine. So water content will come back to normal. As soon as it comes back to normal, this production will come back to normal level. Opposite of that, too much of salt or sweating, water content of the blood becomes low because of sweating. Brain will be stimulated, more production of ADH, because now here the osmolality will change because of too much of salt or sweating. Sweating will lose water and salt. So too much of salt or sweating will produce abnormal osmolality. So as soon as the osmolality has changed, there will be more production of antidiuretic because you want to balance out the osmolality. So high volume of water reabsorbed by kidney, it will make blood again diluted, urine output will become low, concentrated urine, small volume of concentrated urine, water will be retained, so it will produce what we call as back to normal. So water content will become back to normal. So these are the different same water deficit, increase osmolality, ADH secretions will increase, plasma ADH increase, water reabsorption, and decrease water excretion, and this will try to retain water. And as soon as that stage comes, as soon as the water level becomes normal, there is a negative feedback and the ADH production will stop. So these are what will happen in a water deficit or what we call as a dehydration. So it is through a volume or via what we call as osmolality. Also, decrease in the central venous pressure and blood pressure will stimulate the baroreceptor, and even a stress can also stimulate the baroreceptors. During stress, directly it will stimulate without stimulating the baroreceptor. Sorry. During stress, it will directly stimulate the hypothalamus to release ADH. So this is same shown in a different pattern. This is water excess, excess of water ingested. How does it act? Plasma volume, if becomes less, what will be the way? So these are the two different, again, same thing explained with volume, and this is with excess of water ingested. This is same shown in homeostasis of water level in blood. What will happen if the water level drops? What will happen if the water level rises? Means hypervolemia, hypovolemia. This is partial, it is also acting via the CSF. If there is any change in the CSF pressure or sodium, this is the feedback system what is acting. So there is a set point. If set point is at higher level, how it acts. If set point is at low level, how it acts. I am not going into detail. If you are interested, at your leisure time, you can go through. So vasopressin secretions is stimulated by blood volume and osmolality. And second is baroreceptors, that is increase or decrease in the blood pressure, inhibited or stimulated. There are other factors like pain, fear, trauma and stress, and also sleep will disturb. This all will stimulate. All will stimulate. Fall of blood pressure will also stimulate. Decrease in blood volume also will stimulate. So in fall of blood pressure and fall of blood volume are most powerful stimulant for ADH hormone release. So we call as osmotic stimuli or a non-osmotic stimuli, or there are some what we call as osmotic inhibitors and non-osmotic inhibitors. So there are some osmotic stimuli like osmoreceptors are stimulated located in anterior hypothalamus, and impermeable solutes like sodium, sucrose, mannitol, which crosses blood-brain barrier and can also stimulate sodium potent stimulators, or hyperglycemia and uremia. They are also, but they are less potent. So this can be the additional stimulus. While non-osmotic stimulus are hypovolemia, pain, emotion, stress, even nausea, vomiting also increase the ADH hormone level. Pulmonary disease like pneumonia, tuberculosis, CNS disease like stroke, meningitis, subdural hematoma, in geriatric hyponatremia, cirrhosis of liver, nephrosis, etc. And these are some of the conditions which produces excess of production of ADH hormone can end up with SIDH. Other non-osmotic stimulus, we already mentioned some of those: pain, stress, sleep, exercise, etc. There are some drugs like catecholamine, nicotine, barbiturates, opiates, prostaglandins, anesthetics, hypovolemia, hypotension, stimulates AVP secretions due to enhanced sympathetic activity. Alcohol, phenytoin, sodium, glucocorticoids has got negative effect on secretions. So alcohol, phenytoin and glucocorticoid will inhibit the AVP productions. And plasma osmolality, if there is a increase in plasma osmolality, it will decrease AVP production. Sorry, it will increase the AVP production. So as the plasma osmolality increases, there will be release of ADH hormone. Osmotic inhibitors, non-osmotic inhibitors are arterial blood pressure increase or increase in the blood volume, while osmotic inhibitors are increased water content and hypoosmolality. So inhibition will be done by hypoosmolality, but if hypoosmolality increases hyperosmolality, then it will stimulate. Drugs like anticholinergic drug, atropine, ethanol, phenytoin, lithium, caffeine, etc. will inhibit the production of ADH. Inhalation of carbon dioxide also can inhibit the production of ADH. So these are the material which increases, these are the material which decreases ADH production. We have already mentioned the most powerful stimulant is plasma osmolality, increase in plasma osmolality more than 280, hypovolemia, hypotension, nausea, hypoxia, and some of the drugs like nicotine, cyclophosphamide, morphine. While decrease in ADH production is decreased plasma osmolality, increased blood volume, increased blood pressure, opposite of these three. Drugs like alcohol, clonidine, haloperidol will decrease the production of ADH. These are all the other which can also stimulate the ADH production. These are all which will inhibit alcohol, adrenergic stimulators, ANP, phenytoin, sodiums. Now, there are some conditions which will produce certain disorders. By and large, the ADH production is normal. Normal physiological overproduction, underproduction will be there, or what we call as a stimulation and inhibition will be there depending upon all the different factors what we have mentioned. But there will be some condition where there will be hypersecretions. There are absolutely rare where there is an hyperplasia, adenoma or adenosarcoma or MEA which produces ADH hormones. But ADH hormones hypersecretion can occur and it will give rise to what we call as a SIDH. It is very common with CNS pathophysiology like stroke, intracranial hemorrhage, raised intracranial pressure, sodium imbalance, etc. While destruction of hypothalamus, post-surgical, post-radiation because of drugs, there can be hyposecretions. And because of that hyposecretions, you will have a condition we call as a diabetes insipidus. And in that particular, we call central diabetes insipidus, where there is a lack of ADH hormone production by hypothalamus. Hence, there is decreased production of ADH. Or even if ADH is produced, but it does not have any action on kidney, because kidney cells, that is distal convoluted tubule cells, does not respond to ADH, then we call that as a genetic or primary nephrogenic diabetes insipidus. We'll be discussing in detail when we talk about diabetes insipidus. If hypothalamus is at fault, ideally we use the word secondary. And if posterior pituitary does not produce or release ADH hormone, we call that as a primary. If in a proper sense, if you look, hypothalamus is producing the hormone, manufacturing and transporting that to the posterior pituitary, and then it is released from posterior pituitary producing the action. But still the word utilized is primary if posterior pituitary is at a fault. So posterior pituitary disorders in ADH hormone, low level will be classical in diabetes insipidus. ADH hormone is produced in a normal quantity but does not have an effect on a kidney. We call nephrogenic diabetes insipidus. And in a nephrogenic diabetes insipidus, there are two varieties we call as a primary or secondary. In primary, it is a defect in the kidney, while in secondary, it is because of some secondary pathophysiology. Now there is posterior, or we call it a distal convoluted tubule, does not reabsorb water, and that gives rise to diabetes insipidus. Also, because of a low level of ADH, you can have hypoglycemia and hypotension because of release of or a loss of water, plenty of water, that will produce hypotension, hypovolemia and hypotension, and there is low level of ADH. While excess of production of ADH hormone, there is one syndrome called as Schwarz-Bartter syndrome. This is absolutely rare, not very common, but once in a while you do come across this. And SIDH is one condition we call as inappropriate secretion of ADH hormone in relation to osmotic pressure and volume. And also ADH hormone increased level has got an effect where you can utilize that particular property on pancreatic secretions. So if there is an increased ADH hormone production, it will have a decreased pancreatic secretions productions. So in a person with a Schwarz-Bartter syndrome, it occurs very commonly after surgery, particularly on an adenoma. Once in a while, in a case of a bronchogenic carcinoma, we call it a oat cell carcinoma or a small cell carcinoma. It is an ectopic production. And in that ectopic production, we also use the word paraneoplastic syndromes. And it is associated with severe hyponatremia, mental confusion, and sometimes even person becomes unconscious. This is that particular classical example. There is an excess of secretion from this cell. Ideally, these are not the cell which are secreting normally an ADH hormone. So small cell carcinoma of lung or oat cell carcinoma of lung will secrete lot of ADH hormone, and that will produce what we call as SIDH. And that is also one of the conditions which will be responsible for Schwarz-Bartter syndrome. In investigations, history, physical examination, systemic examination is most helpful. Hormone level assay is the most essential and confirmatory. If ADH hormone is less, it is in favor of diabetes insipidus. If ADH hormone is more, it is in favor of SIDH. radiological studies to identify damage in the hypothalamus or damage in the posterior pituitary. Radionucleotide study will also help you. You will have to find out the effect of a hormone by doing urinary osmolality, blood osmolality, sodium level, urinary sodium level, etc. So that will help you to identify the different types of disorders in diabetes insipidus as well as in SIDH. If you want to test out defects like diabetes insipidus, you will have to do a stimulation test, or in an SIDH, you will have to do what we call as an inhibition test. As far as the disorders of ADH is concerned, in diabetes insipidus, we'll be discussing in detail separately. You will use what we call as a desmopressin or DDAPP, DDABP. Pitressin is one of the preparation which is utilized in post-operative abdominal distension, because it will increase the peristalsis and decreases the abdominal distension by gas expulsion. And also it is utilized before taking an abdominal X-ray. If you want a good quality X-ray and expels out all the gas contents, you give pitressin before taking an abdominal X-ray. These are some of the additional use of pitressin. There are other uses also of pitressin. I am not going into detail regarding that particular part. So in a diabetes insipidus it is utilized. Also it is utilized in a person who has got a low level of ABP. In hypoglycemia it can be treated by a measured glucose administration. In person with a hypotension you can utilize fludrocortisone and midodidine to treat hypotension and increase the blood volume, which will help in increasing the blood volume. Or you can utilize nicotine, phenothiazine or tricyclic compounds to increase the ADH production. These are all the other additional use. Here I end my lecture on ADH hormone. We'll see you some other day for next hormone, that is what we call as oxytocin, and other disorders of ADH hormone, that is SIDH.